Great to see all of you. I'm sorry that we're competing against the semifinal. I don't know that I'll be able to do as well, but we're going to have some fun here and then catch up on the game later. At this point, I first want to thank Karen and Franz, Paul, Sari, the whole team that has made this happen. Thank you so much. This has been a special symposium. And what I hope to do in the next little bit, without trying to take more time than you have allotted, is to discuss a topic that I think is relevant to the concepts of precision medicine, personalization, and the interface between those. And in relation to that, we're going to briefly discuss the incidence, mortality, and risks of cancer, briefly discuss a multidisciplinary clinic that relates to then a study that I am leading. And before moving on, my disclosures include that I'm consultant through the end of this year with Natera. I have anticipated funding for this study from Natera, have had honoraria from Sandoz, and I'm also an associate editor for the American Journal of Transplantation. Many of you know that people with organ transplants are 2 to 4 times higher risk for cancers compared to the general population. And that results in a cumulative incidence over the course of 15 years of 10 to 15% of those patients developing some type of cancer. That's a pretty significant issue, and it's a rising issue as we've done better with controlling and managing cardiovascular disease and infection, the 2 other competing causes of death. So the most common cancers in our post-transplant population include non-melanoma skin cancer, mostly squamous cell carcinoma, non-Hodgkin lymphoma, kidney cancer, and you'll notice that large blob, the Kaposi sarcoma, is a massive risk in a very small subset of patients, mostly in the Mediterranean. So we don't see that often in North America, but it's something to consider in complement to the non-melanoma skin cancer as the most common type of cancer. The risks for cancer in general, and yes, these are broad risks, include age, of course, preceding comorbidities. So those with diabetes and end-stage kidney disease are at higher risk for cancers independent of their transplant status. Tobacco use in the past or present, pre-transplant cancers. Immunosuppression leads to a number of other risks for developing cancer that we'll talk about. And yet we don't understand a lot of the mechanisms behind these risks, nor other risks that we haven't identified, including those in underrepresented minority populations. How does it happen? Well, a number of fundamental things happen in the immune system when we suppress the immune system, especially the adaptive immune system. There's a reduce in cell number and function across the entire immune system, including antigen-presenting cells, NK cells. That decreases tumor surveillance. In addition, there's an increase in senescence of T cells, and those T cells normally perform surveillance. So when they cannot, then there's decreased antiviral and anti-tumor response. And then separately, there's an increase in T regulatory function and number, therefore decreasing tumor response further, all leading to a greater risk of cancer in our patients. Unfortunately, that leads to a greater risk of death. And we're seeing now that cancer is the second leading cause of death in our post-transplant patient population. It used to be third. We've done better with infection control, and now it appears to be second behind cardiovascular disease. You'll notice from this well-done registry cohort study done in Ontario that, again, cancer was the second leading cause of death, and a standardized mortality ratio of 2.84, meaning 2.8-fold higher risk of death from cancer compared with the general population in Ontario. And the cancers that are more common in that population as the rest of the world are cancers that are affiliated with infections in some way, and most often oncogenic viruses. So this leads us to need to personalize our medicine. And in the history of our personalization of medicine, we've talked a lot about and need to focus on cancer type and stage when patients have cancer in the setting of transplant. And yet there's a lot more that we need to understand and apply to our care for our patients. And that includes developing and using biomarkers appropriately, understanding and mitigating off-target effects of therapies when we use them, and then addressing comorbidities and patients' life goals in the context of those challenging situations. Oncology has done really well in the last 10 to 15 years, including developing amazing immunotherapies for a lot of different types of cancer. And that includes immune checkpoint inhibitors, bispecific antibodies, CAR T cell therapies. And all of those are intended to focus on upregulating or changing the immune system, especially upregulating the T cell to target the tumor cell. That's been remarkably successful in a lot of ways, but with some downsides, especially in our transplant patient population. In addition to the general immunotherapy-related adverse effects that can happen for anybody, there's the risk related to rejection. And that's in part because those therapies are targeting the exact cells that we're trying to suppress with our immunosuppression, calcineurin inhibitors, along with IL-2 receptor blocker, antimetabolites, steroids, and others. So I want to tell you a story as we think about the potential of this study. This is a man that I've cared for. He's an 83-year-old former physician and former flight surgeon, enjoying his retirement as a docent at the Seattle Museum of Flight, with a history of atrial fibrillation, Addison's disease, and a kidney cancer back in 2010. At that time, there was no evidence of local invasion. So after more than enough time waiting on the wait list for a kidney transplant, he received a kidney in November of 2016. Unfortunately, 3 years later, he presented with neck and back pain, and we found him to have a C2 vertebral lytic fracture with a lesion consistent with metastatic renal cell carcinoma. We proved that. He underwent surgery and radiation to address those components immediately. But then there were the question of what do we do with the systemic components of his cancer? And he had some really good questions. Should we change his immunosuppression to help manage the cancer better? Were there any diagnostic surveillance tools that may help us in that process, including for the cancer, looking for minimal residual disease or rejection? Would immunotherapy be acceptable? And I put up the faces of the two Nobel Prize winners related to immune checkpoint inhibitors, Dr. Hanjo and Allison. And since these agents have come forward, there's been marked improvement in general population response to many solid tumors. And yet, in the transplant population, we haven't been able to use them in the same effect, in part because of the risk of rejection. This is a systematic review that I performed with colleagues at the Fred Hutch, and we looked at all patients who have been treated with checkpoint inhibitors for cancer of some advanced type. And we found that approximately 82% of them developed a rejection within 2 months, 7 weeks of starting therapy. So that's a pretty significant amount. And I would say that when we think about how do we address the cancer as a potential cause of death, at the same time of rejection, including not just for kidney transplant recipients, for any organ transplant recipient, heart, lung, liver, whereby that organ is keeping them alive, we have to balance that unfortunate, serious challenge. And I would suggest that we need to do that with our patients and then with the experts. So what do we do for this man? Well, he was interested in going ahead with checkpoint inhibitor in addition to a VEGF inhibitor. So we added pembrolizumab and axitinib. And this was in October of 2019. We switched him from calcineurin inhibitor to an mTOR inhibitor based on the data that may mitigate the risk of rejection while enabling an anti-tumor response. And we continued with his steroids in part because of his Addison's disease and low dose antimetabolite. He was able to continue on for 2 years, actually through November of 2021, when he unfortunately passed away of his cancer. Yet he was happy with that relative to what could have happened without the options. So I frame that as a part of what can we do for our patients in the context of our current diagnostic and therapeutic opportunities. And part of what I think the opportunity relates to is utilizing diagnostic tools to identify when cancer may be present in the background after what we thought was a cure, for instance, in this man, and when rejection of an organ transplant may be happening. And for those of you in organ transplant, you may be familiar with cell-free DNA. Briefly, I'll touch on it. The idea is that all of us have DNA in our bloodstream that has been released by cells for reasons either apoptosis or necrosis. We may be seeing active release, but for the most part, I think it's because a cell has broken. And this was found way back in 1948, initially related to pregnancy and being able to distinguish fetal from maternal DNA. Since then, we've been able to then move these assays forward and understand that the concentration is relatively low, 50 nanograms per ml on average, and has a really short half-life, only 30 to 90 minutes. So in that way, changes that happen in a person's body, of course, can be marked difference, but if one takes an average over multiple measures, one can see what there is for cell-free DNA from a recipient of a transplant. And to give you an example of that, the donor-derived cell-free DNA assay, which is produced by multiple companies, has the ability for us to draw a blood sample from a recipient, and then using polymorphisms, SNPs that have been standardized across the general population who are non-transplant recipients, and then compare that with donors and recipients, we can then use that for relative accuracy to define a potential rejection. More often than not, that is an antibody-mediated rejection. It's less common for it to be a T-cell mediated rejection. So that is a potential limitation. If we pivot to thinking about the application of cell-free DNA in cancer, there also has been a lot of movement forward in trying to identify the best samples and location for samples, including cerebrospinal fluid, saliva, pleural fluid, ascites, stool, urine, but more often than not, it's blood. And what needs to be done in order to define and create an assay for cancer, or what's called circulating tumor DNA, is that a biopsy or a sample of the tumor needs to be collected, and then polymorphisms of that tumor can specifically be defined separate from that recipient or that person that has the cancer, so that those polymorphisms can then create or the assay can be created for that specific set of polymorphisms of that tumor. From that, a patient could have ongoing surveillance of their condition, looking for what's called minimal residual disease or recurrence of their cancer. And in our case, I'm interested in both residual disease along with transplant rejection. So I want to take a minute and introduce you to our cancer center and our clinic as a framework for this study. So 1.5 years ago, I created at the University of Washington and the Fred Hutch Cancer Center, both a research center titled the Center for Innovations in Cancer and Transplant, and a multidisciplinary clinic at the Fred Hutch Cancer Center. The research center has one main focus, and that is to establish and run a collaborative environment, including a national bioregistry, where we do multidimensional and multidisciplinary research. It includes patient-reported outcomes, epidemiologic, and translational work. We fully intend to start and then reach out to cancer centers and transplant programs, not only in the US, but beyond, into Canada and around the world, in order to really amplify and accelerate the work that we can do together. Bringing it back to the patient, it was important for me to actually bring the providers to the patient instead of the siloed care that historically has been performed. So we do as well a job as we can in transplant clinic, separate from our cancer clinics, and yet there's a separation, often even physical separation of care, that leads to diminished abilities to really synergize and optimize patients' outcomes. So we established this multidisciplinary clinic. It's a consult clinic at the Fred Hutch, where we address questions for patients that have cancer before and after organ transplant. Questions like when to proceed to organ transplant after cancer. Separately, for those who have had an organ transplant, what are the optimal cancer and transplant therapies to help them thrive? So we have an in-person clinic, but we also can do telemedicine. Right now, currently in Washington State and Alaska, hopefully be able to expand that further. We can see 3 new patients along with a return visit every time we have the clinic. And patients themselves can refer themselves to the clinic, or providers can refer. In the first hour, patients are seen by one provider. An oncologist will see one, transplant doctor will see another, and then we'll switch. And the transplant doctor will see that first patient, oncologist will see the second, with the idea that for every person coming into the clinic, the doctors seeing them are experts for their specific condition. So I've been able to recruit 17 oncologists and 4 transplant doctors to see patients according to their cancer type and their transplant condition. So if you had a lymphoma in the context of a liver transplant, it would be the lymphoma specialist and the liver transplant doctor seeing that patient. Or maybe it's kidney cancer in the setting of a kidney transplant. It would be those two specialists. It does take some behind the scenes work to make this work out. And yet we're bringing together experts in order to optimize patients' care and outcomes. So this leads me to the study that I want to introduce you to and get your feedback. So we've titled it DETECT, DNA Tests for Early Detection in Cancer and Transplant. And the rationale for doing this study, as you know, cancer is the second leading cause of death in our kidney transplant recipients. Immune checkpoint inhibitors are now the primary therapy, the frontline therapy for many solid tumors, and yet all of our organ transplant recipients have been excluded from those trials because of their immunosuppressed condition. Recipients with cancer then have a much higher risk of rejection, on average 40 to 50% rejection, typically within 2 months. So could we use diagnostic assays to enable surveillance of these recipients being treated for cancer, including when they're treated with checkpoint inhibitors? So this is a proof of concept prospective monitoring study when patients are treated for advanced cancer with immune checkpoint inhibitors. And the intent is to apply precision medicine approach, utilizing circulating tumor DNA and donor-derived cell-free DNA to prospective care of our patients. Our hypothesis is that these assays will enable early detection of cancer recurrence along with rejection, thereby improving patient conditions and potentially outcomes. So the eligibility criteria, as we've written them, include University of Washington and University of British Columbia. We intend to recruit 20 patients with advanced immune checkpoint inhibitor eligible cancer, with the intervention cohort being those treated with checkpoint inhibitors and the control cohort being those who would be eligible for but treated with non-checkpoint inhibitor-based therapies. We would then follow them from the time of their screening and consent, including getting the diagnosis, staging, and tumor to then create the assay for their cancer surveillance, and measure both the circulating tumor DNA and the donor-derived cell-free DNA at these Christmas tree points a long time over the course of 1 year. The primary endpoints would be donor-derived cell-free DNA levels during systemic therapy compared with pre-treatment and compared with non-checkpoint inhibitor results, and circulating tumor DNA as well at the same time points. I've mentioned a number of exclusion criteria, but one thing that currently is limiting is that we can perform these assays on solid tumors. We cannot perform the circulating tumor DNA yet on lymphoma or heme malignancies. So we will not be recruiting lymphoma patients nor CNS tumors for similar reasons. Otherwise, it's mostly obvious exclusion criteria related to being able to distinguish DNA. These are all adults and kidney transplant recipients more than 3 months post-transplant. So I guess I want to first highlight that we have an ongoing need, and that is to identify patients at risk for cancer and manage their health better for better outcomes, knowing that they're 2 to 4 times higher risk, and it's the second leading cause of death. That cell-free DNA effectively identifies rejection and cancer recurrence. The question is, can we utilize those assays in our high-risk patient population? And so I think this study is one of many that can help to determine how to better utilize diagnostics and therapeutics currently available. Like others who have acknowledged, we cannot do this work without many. It is definitely a team, and that includes patients, along with all the transplant professionals, team members across the board. I want to also acknowledge my cancer research team, including Caitlin Gard and Barbara Kavanaugh, who have continued to work hard back at home while I'm doing this fun work of talking up here. So I have a few minutes left. I welcome questions, comments, suggestions on how we can improve this study. Thank you.
Thank you for the talk. Do we have any, please, questions?
That's some amazing work. I mean, multidisciplinary clinics like that, where you bring professionals together who wouldn't always crosstalk, is just like a model for the future. So that's I totally commend that part of it. I do wonder, in you're sort of including all solid malignancies, and I sort of recognize that just recruiting patients for this could be a real challenge in a lot of ways. There's so much heterogeneity with all of these solid organ malignancies that the downstream analysis of that will be challenging. If you just pick like kidney cancer or something like that, I like that you're including everything, because the more people that you can get involved in it, the more potential knowledge you can derive from it. But I definitely recognize the challenge of recruiting patients, and I just wonder how to do that in the analysis downstream with all those different malignancies.
Yeah. So I think it's an important point that we recognize there's two competing challenges in this study. One is that it's a relatively rare condition to identify a patient with advanced cancer at a point where we could then recruit them into the study across all tumor types. The more common tumors that present are immunologically responsive cancers, like you said, kidney cancer, metastatic squamous cell carcinoma or melanoma, all of which would be eligible for a checkpoint inhibitor, yet they're not the same cancers. And so I think this is intended to be a proof of principle where we could then refine our understanding of the ability to apply the assays across different cancers in relative ways that are of value, and then move to a multi-center study beyond what we have here. So I definitely welcome that, and we'll figure out where we go from here. Thank you.
Ali?
Hi. So I'm a little unclear as to when these patients are getting enrolled. You say that you're using ctDNA to look at cancer recurrence, or are you just monitoring tumor response to the therapy?
So if I heard you right, you're asking if we're following for tumor response to therapy or recurrence. Is that correct?
Right.
So the intent of this is to have a baseline measure at the time of diagnosis, and then with their systemic therapy plus or minus surgery or radiation, then track both those who have established remission early versus those who have the start of therapy at that time point, and whether there is a trend that correlates with their cancer progression or control. So it is characterizing the natural history across multiple components of their condition. And I don't think that right now, because of the advanced cancer conditions that we're going to recruit, that we'll be able to define only those who have already achieved remission prior. Rather, it will be a combination of those who are started on systemic therapy at the outset, plus or minus other therapies, to see whether there is a response that then correlates circulating tumor DNA with their cancer outcome.
So what is the ctDNA adding to the mix here? So the ctDNA would be useful for those who were completely resected, for example, and then you're monitoring for recurrence.
So yes, it would be possible if someone undergoes resection of a primary tumor, and we can then see a marked improvement with that, and then track for minimal residual disease and recurrence. In addition to that, those who are treated for advanced therapy or advanced cancer with therapy that is systemic, one could then at least postulate that the circulating tumor DNA would provide an earlier point of prognosis than imaging, for instance, or some other clinical analysis for progression than one would see otherwise.
So it's the quantitation.
I'm sorry?
Quantitation of tumor burden.
Yes, as best as we understand it.
Great. And let's thank Dr. Blosser again. Let's move on to the next talk.